Don't shoot. Police in our schools, just to name a few. Welcome to the revolution. It begins with you. Fannie Lou, hang tied when it comes to this shit. 1, 2, 3, 4. We sick of the bullshit. 1, 2, 3, 4. We sick of the bullshit. 1, 2, 3, 4. Sick of the bullshit. 1, 2, 3, 4. We sick of the bullshit. 1, 2, 3, 4. Sick of the bullshit.
All right. Good evening, everybody. I'm having a little bit of technical difficulties here this evening, and I don't have the support of Nina today, so it's Chioma running loose with the technology. So we'll see how this goes. We'll be back next week, and we'll be able to save me. In the meantime, I'm going to try and present. I'm going to try and share my screen for these slides. I think that's it for today. Okay, so we're not understanding family policing systems tonight. We are, however, talking about reproductive justice. We are continuing on reproductive justice, or last week rather, we talked about reproductive justice and family policing systems. We were joined by Linda Otey, Renee Davis, advocates from Police Free School, Sam Davis, and Nikisha Winston, and shout out to the Police Free Schools Coalition, who's out in the streets today down by Freedom Plaza. I'm there with them in spirits, and they are attempting to promote a new law that should help in further decarcerating schools, of which we fully endorse. I fully endorse through Cheborn Free and the DC Child Justice Coalition, of which Black Swan, which is a lead organization within the Police Free School Coalition, is also a part of. Tonight, however, we are going to switch up the pace just a little bit. We're going to look at Medicaid as a protective factor, its pitfalls, and it as a protective factor. And we'll be joined by caregiver Shanta Jones. And we are joined tonight by Amelia French, who's also a caregiver and the director of Advocacy with Advocates for Justice and Education, and is an attorney. I always say attorneys are always my best friend. Always my best friends because they really look out for families in this arena in terms of disability rights and disability justice. So I am going to have Amelia join us in just a minute, but there are a couple of things I do want to continue going over. Sharing screen again, and sorry, I'm not more of an expert on how to do this, but going back to those slides. Let's see here. So the last time we talked about family policing, and we didn't really, sorry, my screen, just noticing that it has, when my screen is small, you see it small as well. But we've talked about family policing, we talked about abolitionism, we've talked about captive maternal theory, even refrigerator mother theory. So we're going to continue to introduce new concepts here. So tonight, in the spirit of trying to understand Medicaid as a protective factor and Medicaid with carceral risks to it as well, I think it's important to frame it within the context of colonization and decolonization. So we're going to start with talking about decolonization. So decolonization is a mechanism that will allow for us to, or will allow for the restoration and the reconciliation of colonized groups who have had their power stolen. Every system in society must be decolonized for this to occur. The deep and complex relationship between colonialism and the penal system can be traced back to the creation of the penitentiary system and explored as an ongoing colonial legacy. So just kind of linking coloniality with incarceration. And then there is the vision, the abolitionist vision, to not just end incarceration, but to effectively decarcerate, which is really a creative project of reimagination. So just reading this definition out and what can be understood, Dorothy Roberts defines here as decarceral as if we reject the carceral logic of policing families as the way to protect children, we can reimagine what safety and well-being means and work towards putting that vision into place. The task for abolitionists is not even primarily about abolition as a negative process of tearing down, but it is also about building up and creating new institutions, explained renowned activist and scholar Angela Y. Davis, who was discussing W.B. Du Bois's concept of abolition democracy. Du Bois pointed out that in order to fully abolish the oppressive conditions produced by slavery, new democratic institutions would have to be created, right? That would replace them and not create the same kind of oppressions as we see with slavery of that time that Du Bois was talking about. And since then, it's transformed into prisons, which we know that slavery wasn't ever fully abolished, under the 13th Amendment, with the provision of prisons as the place where one can legally be enslaved, right? Till today. Continuing on to today. And we know that disproportionately prisons are filled up with Black and brown people. But what is less known is that those Black and brown people are also disproportionately represented, represent the disability communities, right? Like they are disabled people, oftentimes unidentified, not identified in schools. And if you guys recall from the time that we had a session, our very first session, I believe, with some of the caregivers who were participants as architects of the South Capitol Street Memorial Act. That's the law that governs school-based mental health in DC that we are looking at with these live streams. Reverend Motley mentioned that the people who committed the acts of violence on that tragic day on March 30th, 2010, on South Capitol Street in Southeast, that all of them were in were known to the juvenile justice system, were under-identified as having different conditions. They are currently incarcerated in adult facilities because they are fully adults now. They're not transition age youth. And this has been known to the system. And it did not prevent it didn't prevent that harm on that tragic day. And so we need working systems that actually decarcerate, because the carceral systems clearly also do not reduce crime, no matter what our fears and anxieties may tell us about how we deal with violence, how we deal with crime. And so we're going to have a very important conversation tonight with some capable advocates that are going to help us talk about that, talk about Medicaid and how Medicaid is part of a visioning of a new world. I think it's really important to recognize. So if people have comments, yes, can't wait to hear from Shanta as well. I hope please continue to make comments, give a shout out to both Shanta and Amelia. We're going to kick off with Amelia, and I am going to read Amelia's bio and then have Amelia join us on here. So Amelia, I gotta find my email. Too many tabs. Let's see here. So Amelia French Amelia French is the director of advocacy at Advocates for Justice in Education. She originally worked for AJE in 2012 as a law student intern. I didn't know that, serving parent advocates, and has returned in 2022. She is a second generation Washingtonian with over 8 years of experience serving the DC community. Some of the hats that she's worn include union organizing, tenant organizing, providing legal services to DC residents. She has two children in the DC public school system with special needs and has her own struggle in schools because she was diagnosed with ADHD. She was not diagnosed with ADHD until she was an adult. Amelia is committed to serving marginalized communities in the greater public interest. After being admitted to the DC bar, she volunteered for a year at DC Volunteer Lawyers Project, representing domestic violence survivors. Her commitment to public service is exemplified in her decision to obtain her Juris Doctorate from the University of District of Columbia, David A. Clark School of Law. While in law school, Community Development Law Clinic, CDC, she represented low-income District of Columbia housing cooperatives in rapidly gentrifying areas. Did not know that. And we'll be circle back on the cooperative situation there, because Amelia, I don't know if you know, but we are incubating a co-op, Neuromama. So it's good to know that you already have that, some understanding of co-ops. Back to on track here. So Amelia served as a lead student counsel in a successful negotiation against the DC Office of Tax and Revenue to prevent the tax foreclosure and displacement of a housing cooperative client. Prior to joining AJE, Amelia managed a pro bono program and fraud prevention protection as ZDEC DC, if you pronounce that for me. She was a staff attorney / Victims of Crimes Act fellow. Amelia was also appointed by Muriel Bowser to the Domestic Violence Fatality Review Board, where she served from 2019 until 2022. So very honored, excited, and can't wait to get into dialogue with Amelia. Hi,
Hello.
Amelia. Oh, and I forgot to say, Amelia is a proud member of Delta Sigma Theta Sorority
Yes.
Incorporated. Hey, Soror.
Hello, Soror.
How are you?
I am doing well.
Well,
Thank you.
thank you for joining us tonight. And we have some caregivers that hopefully will ask questions in the chat as well, or add commentary based on what we're going to unpack. So I want to just, while you're with me here, and as I continue to explore my technology issues, I just want to go over some brief things about Medicaid. But before we do that, I just want to just have a dialogue with you about you, get to know more of your story, reading your bio, things I didn't know. And we've been talking for a minute. So can you just, floor is yours. Can you just say a bit about you? Like, what are you passionate about in terms of the work you're doing, particularly now? What brings you to this? How is mothering and lawyering in this same pot? How does it feel for you?
Yeah, so what brought me to this is really because when I grew up in a predominantly white area, faced overt racism. And also, as I grew older, I saw just how that trickles into different policies, how I was treated in other aspects. Like when I was carrying my son, he was born at 27 weeks. I had preeclampsia. And every day, I wasn't diagnosed when I should have been. Every day I used to call the doctor's office and tell them, something was wrong. I gave them all the telltale signs of preeclampsia. And still, it took me going to the ER, sent home over the weekend, to then only be told to go to the ER again. And then my son was delivered by emergency C-section. So I am just kind of frustrated at how we can be ignored. I know this is kind of part of the conversation that you had last week, but it's just very frustrating when you're still speaking up and you're being ignored over and over again. And then I have just seen, as I grew older, the struggles I had in school. I used to do homework until like 10 o'clock at night in elementary school. And, for that to consistently happen and it to not appear as if I needed any additional support, I just kind of flew under the radar. And so I just have been very adamant as an adult that, if I noticed anything with my children, that I was going to speak up and ensure that they had the supports that they needed. And even in that case, that was a struggle with the school, with the schools a lot of times over the years. And I have gotten to a place where they are at a great school. I think that they're getting the supports that they need. And it's just nice to be able to give back to the community, because I really do feel like it takes a village to raise a child. And I just want to be that support for other parents that may have been in the same situation as myself and feeling like this is just some insurmountable force. And so I'm just kind of really glad to be back at AJE. Like you talked about, I did intern with them when I was in law school. And so, yeah, it's nice to be here.
Yeah, I mean, we joke about like you never really leave AJE, right? Like once you're in the family, you never leave it. So AJE, Team AJE for life, Advocates for Justice has touched so many of us, and I'm really, really grateful that you're a part of leading some of the work. You're leading the advocacy work now. So just want to talk a little bit before like I start kind of digging into Medicaid. If we can just talk out like, just what is the situation on the ground that you see, right? On both education and healthcare, and how does that impact the work that you do, and maybe talk about some of the projects that you do through AJE to speak to some of these conditions.
Yeah, so one of the projects that we have is the Health Equity Project. And this project is being led by a group of parents who have gone through a certain training. And then after that training, what they're doing is developing this health advisory panel. So they're currently in the stages of inviting professionals to the fold that can kind of help inform the work. They are going to serve as like non-voting members to ensure that the power stays strictly with the parents. I think that oftentimes in these spaces, the communities that are being serviced are not, their voices are not elevated enough. And so just ensuring that that power just kind of rests with them throughout this process. And so some of the concerns that they have articulated, well, at least one of them has been essentially, going to the doctor's appointments and feeling like the doctor doesn't know their child, and specifically the disability that their child is struggling with, and how that's going to present at a doctor's appointment. And even though the parents may continue to call in advance of the appointment to ensure that certain measures are in place, just feeling like there's some sort of breakdown in communication there, and wanting to do something policy wise within the doctor's offices to rectify those issues. So that's at least one of the priorities that they've identified, and just trying to fully support them in exercising their ability to connect with doctors' offices, health insurance companies, and things of that nature. And so that's just kind of what we're seeing anyway on our end.
Right. And in schools, do you feel similar kind of communication gaps exist, or are there other issues that stand out to you?
I definitely feel like for schools, there are communication issues, more so I think between the parents, in that they aren't always feeling very connected with the schools, especially, or with the other parents at the school, especially for parents whose children are taken to school by ICDOT. And so they just have limited physical contact with the school. So it puts them in a predicament where they just don't have as many opportunities to connect with other parents at the school. And so that is certainly a concern. And so one of the things that we have done is created something called our school-based advocacy program. And that program, what we're working on is showing parents just really how to create opportunities where they can talk to other parents, where they can learn about special education law, because for those that don't know, AJE is the federally designated parent training and information center. So what we do is we provide parental support, trainings on special education law. We have tons of resources for that. AJE actually was founded in 1996 by alum from my law school, actually UDC, before it was called UDC. But yes, it was formed in 1996, and the law students were really just trying to understand, like, is there really a need for education advocacy? And so there was a project that started, I think, with about 16 families on in Ward 6, 7, and 8. And then after that, we've really just kind of grown to be servicing at least 2,500 families every single year. And so a lot of that is through our one-on-one assistance. It is through different intakes that we get on a daily basis. And it's also through our advocacy programs. So we have like I was saying, the school-based advocacy program. We're really trying to foster a community amongst parents, but then also allow them to be able to effectively communicate with the school administration, especially in the context of IEP meetings, because they can sometimes be very emotional for parents, because we are really concerned about how our child is going to be able to develop across their educational experience. And then we understand also that the formative years are really just that. And so, and how they can really play into your child's ability to lead an independent life once they graduate from school. And so really just trying to, like I said, foster that community between parents, and also bridge the gap between any breakdown in communication between parents and the schools. And so that's really why we've created the school-based advocacy program. We also have our parent ambassador program, which it really functions like a therapy session. So we really get together and we talk about issues that may be of prime importance to caregivers and to parents that have children with disabilities. And one of the sessions we talked about navigating circles where it seems like not navigating social circles where it seems like people don't really understand how it is taking care of a child who has a significant disability, or what that really presents as, and just feeling out of place and not fully supported. One of our sessions, we talked about kind of losing sight of us as individuals, because we are constantly doing things for our children, and just trying to provide that support, and just any needs, assuring that the needs of the parent are fully met as an individual, just because obviously if you aren't taking care of yourself, then what good are you going to be to your children? So
Right.
yeah, I really do appreciate those parent cafes. We host them every month. We have another one coming up on the 22nd. And we also have an educational advocacy boot camp that we're working on. And that is going to be coming up in May 23rd and May 30th. We will have a day session from 12 to 2. We will make it a hybrid session, so you'll be able to participate either remotely or in person. And then we also have a session that's going to be in the evening from 6:30 to 8:30 on the 24th and the 31st of May. And just really trying to provide an opportunity for parents to build power amongst themselves, and kind of talk out what are the issues that are of prime importance, so that they can be elevated and handled effectively by schools.
Yeah, and I keep saying, like, AJE is doing cadre development, like building the troops, right? Recruiting the troops, because there really is this need for long-term wraparound protective support, right? And speaking of protective support and protective factors, I do want to switch paces. We're going to come back later and just tie back AJE in again. And I want to attempt to share my screen one more time and just kind of lay the foundations on Medicaid and have more dialogue with you. And hopefully by that time, Shanta would join in and, just give her her input as well and her experience. So before I even do that, I just want to say that we did go over. So for those who don't know, this is part of a caregiver political education boot camp that's through the DC Child Justice Coalition. And we meet twice a week. So Mondays, we meet internally. And then Fridays, we do these live streams publicly, and we bring on different people that are part of the coalition and or are part of the actual cohort, which we have 34 registered participants and hoping we can continue this program moving forward. So to that, on Monday, we started unpacking Medicaid, and there were some things that came up that I do want to, heads up, I want to address that we started talking about, particularly around school, how Medicaid dollars move in schools. We're going to talk a bit about that. And there was lots of questions and buzzing dialogue with parents or caregivers in the boot camp about that. So Amelia, we're going to touch ground in there and I just want a heads up. So I do not work for the DC Department of Healthcare Finance. I do serve on the Medical Care Advisory Council. So I do feel obliged as part of my civic duties to also be a responsible Medicaid information communicator. And so much of the information we're presenting here is researched information, and also through dialogue with knowledgeable people, particularly those that are part of the DC Behavioral Health Association and the DC Special Ed Co-op, where I had pre-dialogues, informal dialogues with, to really get clarification on some of the things that came up during our cohort meeting on Monday that I didn't have all the answers for. And I feel stronger today to talk about it and get into it. And so I'm just going to share slides, get into it, and I look forward to fruitful dialogue about what's going on in terms of DC Medicaid. And so back to our slides here, decarceral. So just brief history here in terms of basics of Medicaid. So in the 60s, U.S. Congress federally made changes to Title V legislation, and I think that's Title V of the Social Security Act, and that was developed to support maternity and infant care and children projects. And that would be the first, I think, federally allotted slot of money when the Social Security Act was passed in 1925, that was earmarked specifically to support poor families and families of children with disabilities. And so there were children and youth projects that provided screening, diagnosis, prevention, services, correction of defects. I mean, that's clearly research language. It's not my language. And aftercare, out of school time that people are calling it these days. In the mid 1960s, Congress also increased authorization for increasing programs for what was called the Crippled Children's Services, expanding services to those with conditions like epilepsy and hearing impairment. So when it first passed, it was mostly for developmental disabilities and cognitive impairments, otherwise known as intellectual disabilities today. And then later, there was an incorporation of medically fragile and medically complex young people, including those who are deaf and hard of hearing, those with epilepsy, and the lot. And then in much later, the language of that crippled children's legislation would be used to inform the language in the Medicare and Medicaid bill that would pass in 65 under what and would guide the screening, the early intervention principles within that law that are called EPSDT. So these are guidelines offered through the Centers of Medicare and Medicaid, which was established through that same law in 65, to ensure that healthcare providers are providing early periodic screening, diagnostic, and treatment. And so these are timed services, and they're processes that have changed over time. That kind of constitute, how Medicaid dollars are distributed to states, and then the level of accountability on the federal level that they have to do with that. So more things. So part of the things Amelia and I and the team AJE put together for the Community Health Ambassadors Program last year was a Community Health Ambassadors resource booklet, which we're hoping to have copies in the care packages for our cohort participants, who they'll be getting care packages at the end of the cohort when they graduate. And so a lot of the information, a lot of the research that kind of informs tonight's presentation really comes out of that booklet that we also hope to make available for other caregivers. So more things about Medicaid here. So Title 19 of that Social Security Act in 1965 was amended to now create what we know as Medicare and Medicaid, and then the government management system that kind of is the accountability wheelhouse for it, called CMS, Centers for Medicare and Medicaid. So there are criteria for people who become eligible for these programs. Medicaid is a government-funded health insurance program coverage for families and low-income individuals and people with disabilities who fall at or below the federal poverty level, and services look different in every state, and monies are usually distributed in block grants to states, or lump sum to states. And then there are different waiver programs with additional funding that come from the feds. So DC is top 3 amongst all states that have many of their constituents using public insurance. It's the second highest place in the nation for children on public insurance, and the third highest, again, for adults. So in order to be eligible for DC Medicaid, one must meet specific eligibility category to qualify. And that system is determined from in a process once one undergoes enrollment. So as soon as you fill out your application, it's processed through the Medicaid Management Information System. And that's some algorithmic process that helps to determine, using what's called MAGI method, the Modified Adjustment Gross Income, which are a set of criteria such as, how much money you make, how much property you own, how much reserve in the bank, savings you have in the bank, and some other things to determine eligibility. And of course, unfortunately, the way the system currently works is that it pretty much wants you on your knees and at your last stop in order to be able to get public support for insurance. So you have to be about 200% below the federal poverty levels, which I think puts people usually around $17,000 to $20,000 a year, all depending on inflation, I believe, each year. Most states, people recertify on an annual basis. And that's starting the month of April, April? Starting this month, at the end of last month, the public emergency ended. So anyone who is Medicaid dependent, if you yourself are Medicaid dependent, if your child is Medicaid dependent, if you have seniors that you know and love that are in the home, in the community, that are Medicaid dependent, it's really important that they contact their care managers, that they get online using, I will when I'm not talking, I will find and I will paste the link for where you can go to recertify, or you can look back on the archives on our YouTube channel, Chiborn Free, which hosts these webinar series, and you'll see from last week's webinar, week 5, we posted that link as to where you can go, or was it week 4? The previous weeks, week 4 or 5, or week 4 and 5, we posted the links. If I can post the link again as to where you can go to update your mailing address, that will be the primary method that Medicaid, DC Medicaid, Department of Healthcare Finance will be distributing letters to let you know when your recertification is up. Right. And that's going to be happening right now. And a lot of people are going to, unfortunately, I think, be negatively impacted by that. So just doing my little part here. But there are other ways outside of MAGI, getting back on track here, to qualify for DC Medicaid that are not based on MAGI, that are not based on your income, right? And these include various waiver programs, such as Katie Beckett waiver. And we're going to talk about that in just a minute. The modified, I'm not going to get into all of that so that we can get into more dialogue. We went over these during our session. I'm just going to talk about Katie Beckett, and then I'm going to talk about how Medicaid moves in schools, well, and also the MCOs, and then bring Amelia back in to get her feedback on and go deeper, dive in on these things. So Katie Beckett is a waiver program. It's one of several waiver programs under Medicaid. Is one of the most complicated public policy laws that there is out there. Money moves all over the place, and there are many different caveats. So there's straight Medicaid, as you hear people referencing. Those are the people who come in on the MAGI eligibility, but there are all these other sub-funding slots known as waiver programs that are for special consideration, special criteria, different location of access to services, things like home-based services are a part of that. But specific to children with disabilities, the Katie Beckett waiver is a non-MAGI eligibility category. So that means that somebody can have income above the MAGI restricted eligibility criteria for Medicaid, and if they have a known eligible condition that is recognized by the Social Security Administration, because you have to first apply for Social Security income, and then when you get denied for that but are found eligible, if you did not have an income, but you do have a qualifying condition, then you would be able to enroll your child in a Medicaid. Your child can become a Medicaid beneficiary even as the household is income ineligible. So other qualifying factors, including having a child in home that is 0 to 18, who has been identified as having long-term disabilities or complex medical needs. Again, in the District of Columbia, that determination is typically first made by Social Security Administration and then endorsed by DC Department of Healthcare Finance. In rare cases, there are people who can not meet those federal criteria and be eligible for DC Medicaid, but it's a very rare chance that that would be the case. And children must be over income. So in order to apply specifically for this waiver, Katie Beckett, your household would have to be over the MAGI Medicaid income and indicate that you do actually have a qualified disability that's recognized and endorsed by Social Security, and that children are to be cared for in the home and not an institution. So any child that is, even if you are the biological parent and you do not have custody of that child is in an institution, whether that be a psychiatric institution or juvenile justice or foster care, the family policing systems that we talked about last time, that these would be criteria that would make one ineligible if you do not have a child in the home. There are other waiver programs like DC Health Alliance program. This is for residents for adults that are over 21 and are also under the federal poverty guideline. And the real key benefit of this is that DC, as a sanctuary city, also recognizes that that this insurance program is available for immigrants and undocumented people. And then we also have the DC Immigrant Children's Program, which is that undocumented children are also covered. And these are locally paid for. So both the Immigrant Children's Program and the Alliance Program are taking from local funds and not federal funds. And I'm not going to get into but I am going to say, and this is really important, that healthcare finance has changed. One of the, as of April 1st, one of the managed care organizations, so how people primarily receive their Medicaid is through subcontracted insurance companies, private insurance companies that then take on the responsibility for the public insurance program. And in DC, there are technically 3 insurance companies that run Medicaid programs, and they're called managed care organizations because they're supposed to offer care management in order to navigate the system. So that is AmeriHealth. Now it's AmeriGroup. So if you were a Medicaid recipient in the District of Columbia and you were part of Care First, if Care First was your provider, please reach out to Department of Health Care Finance ASAP, because you will need to change your insurance plan because that is now invalid. The new provider is AmeriGroup, right? So instead of Care First, it's AmeriGroup. And then there is MedStar. So those are the 3 primary insurance. And then there's a special category of students, of young people that receive DC Medicaid managed care. And that is the insurance company Health Services for Children with Special Need. It's under a different category called CASIP. And I am not going to guess what CASIP is. I'm going to actually try and look it up. I think, do I have it on another tab? I think I may have it on another tab. I will look that up when I'm not sharing my screen anymore. But there's that. And the very last thing I want to talk about, and then we're gonna have less lecturing here. Medicaid in schools. So Medicaid in schools. So caregivers of the cohort, please pay close attention to this part. So Medicaid is used in schools for IEP and 504 services and clinical behavioral health services at the tier 3 level, right? Separately. And part of why they're paid for separately in terms of if you're receiving behavioral health on the IEP or if you're receiving behavioral health through the school-based mental health program at the tier 3 level, which means one-to-one support, which is technically crisis care or, clinical is tier 3. Tier 3 is tier 3. It's the highest tier on the DC behavioral health tier system. They're paid for separately, but both done through the schools and both done through Medicaid. So schools hired staff that have Medicaid reimbursed based on percentage of population that Medicaid eligible in random moments of time. So that just means that schools become eligible to bill Medicaid based on a percentage of Medicaid eligible children in their school. So a Title I school, which typically represents low-income children, are those that are those campuses that would likely be using Medicaid. Majority of DC schools, public and public charter schools, DCPS and public charter schools do use Medicaid as a payer. Matter of fact, they use Medicaid as the primary payer, right? Because Medicaid actually reimburses at a higher rate than the Individuals with Disabilities Education Act and special education. So Medicaid reimbursements for providers are about 70% on the dollar spent. Whereas if they used special education money, which is also federal, the reimbursement rate is about 40%. Schools use both, right? But so talking about one billing system, random moments in time. Healthcare finance randomly selects clinicians at schools, whether it's contracted with the schools, whether it's those that work with DBH, whether it's those that work for the schools themselves. But these are for those that have IEP and 504. So these are people who are, you will never, a school should never, a school does never, can never, will never use your Medicaid number to bill you in school. However, if they are for the random moments in time, and this works primarily for IEPs and 504s and for school nurses who, give medication and do other things that are in the 504 category, they don't have to document like each child and their Medicaid number, like they're going to plug it into the child. They just need to know that you are eligible and that the parent gives consent, right? And then they have this random selection call system, I guess an average of like 10 clinicians a month. Don't quote me on that, but a number of clinicians a month that are in the schools get these random calls, and they have to tell healthcare finance the kind of activities that are Medicaid billable eligible within that school. So it's kind of a looser way of billing Medicaid. And then there's the claims base. That is the way that people typically use Medicaid, when you put down your insurance number and then you are automatically billed. That also happens in schools, but with the school-based mental health program and other kinds of programs like that, where these, when the schools hire or contract a staff, they can see their client in school. And they are also billing directly to Medicaid for their reimbursement. Now, there's a federal regulation against what's called double dipping, which means that if you're going to do claims-based payments or billing in schools, if a provider says that they're going to provide an hour of therapy for a student in the schools, that same provider, who may be the community-based provider, cannot bill for therapy for another hour of therapy for that same child when they're out of school. So you cannot, even if the child needs it. So even if the child needs, wraparound services, they need their time, their one-on-one time in school, they need their one-on-one time in the community, it just cannot happen on the same day. So that means that if a provider is seeing a child in school and out of school, they have to pick which days. If they're billing Medicaid, if they're doing tier 3 work, they would have to bill Medicaid. They would only be able to bill Medicaid one time for the same child that day. So those are claim-based, and those are like the regular billing. And schools don't need your Medicaid insurance number, but they do ask you for it because this is how they justify their ability to bill Medicaid, and it does give schools extra money. So if a parent thinks that providing that information means that the school is now going to charge you, or even if they want to know if you have private insurance, right? Like they want to know that also so they can report the number of students that are eligible and ineligible. So it's not ever to bill you, but it is useful data to help the school save money and provide care at the same time. But here's the thing. And this is where I'm going to stop sharing screen and invite Amelia into dialogue, is that 40% of the monies from the Individuals with Disabilities Education Act is still being used in the schools, right? So they still have access to Medicaid, to IDEA money, except that they're not bringing in the community in dialogue in terms of how they're using specifically the special education dollars. I think on average, schools are using that money for staffing, for personnel, for paraprofessionals, for special education teachers, and that and the other. But there's no real democratic process locally that helps us know that the schools are paying for related services. They're just paying for related services through Medicaid because it saves them money. But that means that there should be more democratic space allotted and dialogue at the school level as to how you're using the IDEA money and how we can get some of the most abysmal, outcomes for any student category that happens with students with disabilities, right? So I said a lot of a lot of a lot of a lot of a lot. So Amelia, I'd love to know your legal mind, what your legal mind is thinking. Like, how do you? Let's talk specifically about Medicaid in schools, right? Especially because you're doing both the health equity project and the school-based advocacy project. So it seems like, this is a particularly sensitive issue that impacts our families that are caught at that intersection, needing services in school, needing services in the community. And hopefully those services are not crisis care, that they are preventative and early intervention. So what are your thoughts on all that I just said about Medicaid? You're on mute, sorry. I think I can unmute you. Can I? I can't unmute you. You have to unmute yourself. I'm sorry. Well, feel free to go out and come back in if that may hopefully do the trick. Yeah, Medicaid. So anyone in the cohort want to give a comment, give a thought, please put your comments in the chat, especially based on the new information on how Medicaid dollars move in schools. Waiting on Amelia to navigate through the World Wide Web and come back to us, and then hopefully also have Shanta join us in just a little bit. Okay, so I can keep running my mouth as I'm waiting for people to come in. Actually, you know what? I'm going to just play our little sick of the bull BS here. So let's take a small break.
Don't shoot. Police in our schools, just to name a few. Welcome to the revolution. It begins with you. Fannie Lou, Heyman Ty, when it comes to this shit. 1, 2, 3, 4. We sick of the bullshit. 1, 2, 3, 4. We sick of the bullshit. 1, 2, 3, 4. Sick of the bullshit. We sick of the bullshit. 1, 2, 3, 4. Sick of the bullshit.
Okay, still waiting on people to come back. I guess maybe I can I'm not used to doing this without somebody. How can ABA therapists work with your child in school? Okay, so let me address that question. So while we wait on our guests to come back with us, I will, and so anyone else have a question, please put it in the chat. So one thing I'll say is that ABA therapy, the ABA therapist that is your out of school time provider, that is maybe providing you home-based services and community-based services, typically does not come into the schools at the same time unless they have an MOU agreement with the school. And that would mean then they would be able to bill Medicaid during the school day. But schools and IEP teams, unfortunately, are typically resistant because they don't want to mix up their Medicaid billing situation. So as a rule, I think schools typically will tell you, like, if you have a great provider that's providing ABA, and ABA is, again, applied behavioral analysis. For those who do not know what that is, it's a behavioral therapy protocol for autistic people. And so this is Autism Awareness Month, Autism Acceptance Month, my bad. And, ABA is quite a controversial therapy protocol and is not widely accepted within, the disability justice framework and justice world, but many families do use it. And I do, maybe we can have at some point, not during this cohort, but later on in the year, when we do more public dialogues, we can talk about the other behavioral health interventions for people with intellectual and developmental disabilities that is not ABA, more humane treatment, or if there are ABA providers that do more humane delivery of service. It's important. So, I think the politics around ABA is also informs why schools typically don't kind of get into it with the provider base there. And unfortunately, or fortunately, depending on your perspective, ABA providers are not, wholesale part of the school-based mental health. So people who provide organizations, community-based organizations that provide school-based mental health services in the schools under the Department of Behavioral Health program, their contract is with the Department of Behavioral Health. And as far as I know, as a sitting member of the coordinating council, there isn't one of those providers that also provides ABA in the schools. Some of them may provide ABA in their facilities and may be able to provide ABA, if you are also receiving services for them out of school, but that's one way. So thank you, Martinique. Any other questions while we wait on people to come in? Well, actually, you know what? I'm just going to go ahead and play some things, some videos, and then give my commentary on it. So Amelia's restarting her computer. So Amelia's coming back soon. So I do. Waiting on Shanta. But let me see here. Can't seem to walk and chew gum at the same time. Okay, technology is clearly not only not my friend, it's also other people's not friends. So this says, how can high functioning kids with IEPs maximize Medicaid billing services in schools, and can Medicaid transport services be used for out of school time? Oh, great question. So let me see here. How do I talk about this? So the question is, in my opinion, Medicaid transportation services are also as terrible as OCDOT. So I think it actually speaks to how the District of Columbia sees the value of supporting transportation for vulnerable populations. Seniors use public transportation, metro access, and things of that nature. HSCSN contracts with one company that's in Tennessee, I believe, and there's so many issues. I wish Shanta was on here, and Shanta can give us, some of, direct feedback. Anyone that's, used HSCSN contracted transportation, sometimes they get you to your appointment and sometimes they don't. And so it's a very imperfect system, as much as OCDOT is imperfect. But they are two separate pots of money. And there really is no coordination of care that's happening well between the schools and out of school time providers and transportation providers, whether it's through DOT or it's through your insurance company. So you have choices as a parent. As it stands right now, it'll probably be denied by utilization management. And so I didn't present on utilization management, but I do want to say this while I'm answering this question. Let me just touch on utilization management, which I was kind of reluctant to do before. But since we're talking about approval processes in Medicaid, I will also talk about utilization management. So where is that slide? Okay, utilization management. So what is that? Utilization management is the evaluation of medical necessity, appropriateness, and efficiency of the use of healthcare procedures and facilities under the auspices of the applicable healthcare benefit. Some utilization management is referred to as utilization review, or UR. So it can either be UR or UM. In DC, it's typically referred to as UM. The main point of UM is to control fraud and waste spending for Medicaid services, which is both locally and federally regulated and monitored. UM also offers an organized manner in which providers are paid for their services to their customer base. So each managed care organization has a UM division, a utilization management division. So it typically happens when you make a Medicaid request, and you can make a Medicaid request, but it probably won't be honored. It's like any insurance company. You can make a Medicaid request, but it's your insurance company is probably going to deny you those services unless there is a referral made by your primary care provider. So your primary care is your best friend when it comes to accessing Medicaid dollars that you control, not the school controls. And then when that happens, the primary care can put in a direct request to using, your code, the coding system, the DSN code, and will justify that if it is billable, then will approve it or not approve it. And there's a timeline for that, which I don't know very well. At some point, we will gather our friends back at Department of Healthcare Finance to work with our co-op when we start our co-op development later in the year. But for now, this is just Chioma's, Medicaid session. So it's going to not use all the technical terms here correctly. But in any case, you have to be approved. Now, non-pediatricians can also clinicians or clinical providers, those who are licensed, whether it's for physical therapy, occupational therapy, speech therapy, related services, IEP language, they can also bill Medicaid directly and put in a request to and it can be approved or disapproved. The challenge is, though, that they are very narrow, not creative, and almost knee-jerk will disapprove you for things that, you have to, maybe take through dispute resolution, get the ombudsman's office involved before they approve it. So it's very hard to get non-traditional things that don't look like you're going from your home to a doctor's appointment, because that may fall under non-traditional services, right? And so the chances of that being disapproved without Department of Healthcare Finance, the schools, and the out-of-school time providers having some agreement with them, it's going to be very hard to say an either or, right? But the bottom line is that transportation sucks all around. And like if Medicaid transportation or from your MCO transportation went better, and it would only be through HSCSN, that I think that would even be possible. Other Medicaid programs do also offer transportation services. I think every Medicaid program kind of has to do that, can take you back and forth to your doctor's appointment. But in terms of like the level of coordination, the frequency of going to doctors, and the readiness to do so for children who need that transport, and young people under the age of 18 that need that transport, it's really, there really isn't an organized way that the district makes it easy for families to transport their students from A to B. And the recent budget just cut OSSI DOT's budget. I don't know enough about the Medicaid budget, and that's things that we can take back in our Monday session to discover. I can see if I can ask questions before our Monday session. But essentially, and the bottom line is that we will not have access to the things that we need because there's a value judgment in terms of what we do and the quick knee-jerk denial of if we ask for things that they think we're unworthy of. So long and short of that, to just come back to your question, Fari, right? Like, I don't like that term high functioning, low functioning. It's not, if a low needs child needs transportation support, if any child needs transportation support, they should be able to get it as part of either Medicaid or their schools, but both transportation systems are non-working systems, in my opinion. I would love more dialogue on this. I wish my guests were here with me so we can, to other people, but can bounce off. But I am reading the chat, so feel free to push back on the chat. I will say a little bit more about like what I'm hoping. I think that there are important dialogues to be had with council members, particularly those on the Committee of Health, and Councilmember Christina Henderson chairs that. There is $2.5 million. So I participated in a PAVE meeting with Deputy Mayor Klein, PAVE as in Parents Amplifying Voices for Education, and a meeting with Deputy Mayor Klein, who did make it clear that as part of the proposed budget, and we'll probably hear more about that when the government witnesses testify, I believe next week or the week after, for the Education Committee, which was a tragedy. A tragedy. It was horrible. It was 400 and something people. I was signed up to testify. I couldn't continue to wait and participate in the dysfunction. So there are opportunities, and during our week of action, and so heads up, we are going to have a week of action at the end of our cohort, the week of May 10th through May 8th through 12th. So we are planning on going to City Hall. And so maybe these are some of the things we can take directly to City Council members. This is a marathon, not a sprint. These problems are clearly not going to be solved this budget season because the whole process is a mess. And our needs are just not really prioritized. And I see like, caregivers on social media counting down 60 plus days of dysfunctions from OCDOT. Not enough vocalization around the transportation situation in terms of social media when it comes to Medicaid transport. But we know, for those of us who are in community with each other, just how terrible it is on both ends. So I don't see it as a solution in terms of combining them unless we talk about quality and unless we talk about systems, rearranging systems, in ways that decolonize and, stop the resources from hemorrhaging at the top. So I'll say this, my biggest issue with the way Medicaid, and why I say that Medicaid, some of its risk factors is that because Medicaid requires billing, right, or requires licensed clinicians using the medical model of care, of which the disability justice movement is very much against, right? Like, in the times of deinstitutionalization movement in the 60s and onward, I mean, there was this need happening globally for disability justice and disability rights around the world to say that we want to shift from a clinical model of care, a medical model of care, which is a deficit model of care, which says that the fix me model of care, right? Look at going back to just what was presented about, the history of the law. The history of the law itself developed in an ableist kind of way. I mean, the original provision within the Social Security Act provided screening, diagnosis, preventative service, and correction of defects, right? That's how they thought about it before, of which is not how I think about it, and is not how disability justice advocates, I think, should be thinking about it. That we are not broken to be fixed, that we are solvers, we're problem solvers, right? Like, disability communities are part of our culture. Part of the culture of being a disabled person is being able to solve very complicated problems, because you don't show up in any system. So we say nothing about us without us, and we are solution oriented people, because we have to be, otherwise we are dead, right? So the deficit model that the medical system, or the medical model of care, kind of promotes, that Medicare and Medicaid and the Social Security Act, which was passed in 1925, just think how far back. In 1925, institutions were uncontroversial, right? Sending people with disabilities away at very young ages was uncontroversial. Not allowing children with disabilities to receive public education was uncontroversial. Not allowing Black and brown people to receive public education was uncontroversial in 1925. So the laws have not caught up to the federal laws, have not caught up. And certainly the local laws also cannot catch up. Similar, look at the kind of problems that we have in DC in trying to reauthorize our criminal code, and saying that we want to take the power in our own hands as an autonomous, self-governing jurisdiction, to be able to say what constitutes our criminal code. The feds will get involved. Imagine if we try to redefine licensing criteria, licensing structure. We couldn't possibly alone redefine who gets to bill Medicaid, who gets to deliver services that are endorsed by Medicaid and reimbursable by Medicaid, right? So that cuts out a lot of people for the workforce. So let's talk about the real problems of the healthcare crisis. The healthcare workers crisis, or the workforce crisis, in my opinion, and part of, not just my opinion, also through the research for the ACOMA project that we did, which, we'll be presenting in the last few weeks of this cohort, is that, my opinion is simply that clinical workers are just, the reason why we have this workforce crisis is because we have a dysfunctional Medicaid system that is overly dependent on the medical model of care, has made little investments in the social model of care, which is more humane treatment, which is more dignified treatment, which is more control for families and self-advocates. So if we're not doing the real work of shifting mental models around care and care delivery, and who gets to care for people, who gets to offer services. Before Amelia had tech problems, what was really important is that Advocates for Justice and Education works as a peer model, right? Like, you have parents that are certified parent and parent cafe people, and they can go in to communities and offer a level of care that is not endorsed by Medicaid. And that is because they are not seen as worthy, as professional, as expertise enough, as regulated enough by the state in order to deliver otherwise carceral care. Yes, that's right. That's right. Congress just overturned DC's police reform laws for the first time in 30 years. It's a shame. And so we don't have that autonomy to make those kinds of decisions as to how things are built. But on the books, it's still legal to sterilize people with disabilities, people with mental health disabilities in the District of Columbia. And part of the reason why that's in the books is because, again, we'd have to go to Congress to take that out of the law. So while we're not a state, and while we don't really kind of have, the right to go, we don't have people at Congress that kind of represent us with power. We do have Eleanor Holmes Norton, who is, by the way, a caregiver of a child, of her child that she birthed, who's an adult now, with a disability, that we don't have the representation federally to actually, command anything, but we are so heavily impacted. And so that's the coloniality that we all share, but then the coloniality of those of us as people with disabilities and people that also have loved ones that are disabled, and that multiple generation of impacted people have zero control over how the services we receive are going to be delivered and who gets them, and who is going to be paid. So if you're a mother or a caregiver at home right now, and your child requires Medicaid, or your child is eligible for Medicaid, and you've gone through the really painful processes of becoming eligible to receive home and community-based services through, the different home waivers that allow you to receive Medicaid services at home, to create a medical home. If you go through all that trouble to ensure that your child gets a certain number of hours and is recognized as somebody who's medically fragile enough to need that care, the chances that you actually get that care in this era, slim to none. I know this personally, right? Because the fallback is the workforce crisis. But we have solutions that are decarceral and decolonial. It's just nobody will pay for it. Locally, we won't allot monies from our local slot of funding to pay for it. And federally, the red tape around how the monies have to be spent will not be endorsed. So for those of us who are creative, thinking of Renee Davis, who is MacGyver. This is Mama MacGyver, okay? Can single-handedly create recreational programs, can do guided tours, can do nature walks, is neurodivergent, is a neurodivergent caregiver and of neurodivergent children, right? The system would I'm saying Renee because I know Renee. I have Renee's permission, to talk about Renee's, but there's so many Renees in the community, so many skilled caregivers who have so much to offer in terms of really things that help protect people, things that help keep people well, things that care for people. But we don't have the billing structure, the billing system that will actually allow for people to be compensated, and we don't have the local money endorsed. So on this note, the last thing I'm going to share, I think there's some more question. DC statehood is racial justice. Absolutely. It's also disability justice. And isn't school supposed to have ABAs in school? Yeah, supposed to, I think is a stretch. Right? Like they don't have to, right? Personnel, IDEA does not give parents have a lot of rights through the Individuals with Disabilities Act. Making personnel decisions is not one of them, right? So we can't go into an IEP meeting and say, hey, you got to hire this kind of person, or you got to create, you have to participate in other democratic channels that are local. Join the LSAT, the local school advisory team. Join your school's board if you're in a public charter school. Have a seat at the table. Show up at these meetings. Disrupt them. Those are the ways that you can get your school to invest in an ABA therapist if that's what you want, or any other kind of therapy protocol. And because, they're thinking dollars and cents, so you can do that. But I do want to share a bit of the video for Dr. Bazelon, who is the director of Department of Behavioral Health. She testified this week at the Committee of Education. At the Department of Committee on Health and the Department of Behavioral Health's testimony. She said some interesting things, food for thought. Wish I had my panel with me tonight, but we're just gonna have to keep talking to myself here and you guys in the chat. I appreciate the love in the chat. Please keep them coming. But I'm going to share this video and I'm going to talk about it. We're going to talk about it. Okay, so let's see here. How do I? Okay, here we go. Okay.
Pandemic and to make sure and maintain care. The proposed FY24 budget continues support for children and families at home, in school, and is needed during crises. Children and young people have been particularly impacted by the pandemic as disruptions in routine and relationships have led to increased social isolation, anxiety, and learning loss. Studies show that use of social media also has created anxiety and depression as it presents a warped view of reality and challenges body image and self esteem. The school based behavioral health program was set up to make it easier for children and their families to get treatment where kids spend most of their day and where the eyes of many adults are on them. Cities around the country are making mental health supports available in public schools. Washington, D.C. is a national leader as the proposed FY24 budget of 37.6 million funds at least one licensed clinician in every public school through multi-year investments by Mayor Bowser and the council. I have attached a brief breakdown of the proposed FY24 budget to my testimony, which was submitted to the committee. The DBH clinician and CBO clinicians are a part of the school's behavioral health team that could include the school social worker, a lead teacher, a school nurse, and a parent, and is led by the school behavioral health coordinator. Behavioral health clinicians from DBH or contracted community-based organizations are now in 153 or 63% of public schools, and we continue to expand in partnership with DC Public Schools and DC Public Charter School Board. School-based clinicians are expected to provide prevention, early intervention, and treatment services funded with a combination of local dollars and billing through Medicaid and private insurance. To guarantee the delivery of prevention and early intervention services that are not eligible for Medicaid reimbursement, DBH provides $63,153 per clinician for salaries. The total budget support for CBOs is a little more than $23 million and includes $89,366 per clinicians for salary, personal development, and supervisory support. In our performance oversight hearing, we talked about the challenges of hiring and retaining nearly 300 licensed social workers. The proposed FY24 budget maintains funding to support our workforce development initiatives. In addition, DBH will participate in the new workforce development fund proposed in the mayor's budget to support our recruitment. We continue to work with our partners to examine the model to make sure that we are using our significant resources in the most effective way and are reaching the students and families who need support. I want to take this opportunity to address funding for Healthy Futures. The mayor's proposed budget maintains current funding to support Healthy Futures in 182 child development centers. There is no reduction. Healthy Futures funds inadvertently replaced in another program area. The total amount in the proposed budget is $4,124,412. The proposed FY24 budget also includes $28.2 million in federal funds to support evidence-based prevention, harm reduction, treatment, and recovery strategies in our Live Long DC plan to fight the opioid epidemic.
Okay.
Opioid overdose.
All right. So stopping there. So I do love Dr. Bajon. I feel she's very receptive, very respectful, very understanding of the plight of caregivers. I consider her an ally. But I do think when we're talking about school-based mental health, and then we talk about the Healthy Futures program, which is the early intervention arm of that. So while yes, the budget looked like, at first, because there was misallocation. I guess they put Healthy Futures under school-based mental health, which I believe is correct. For years, I have argued that Healthy Futures program, which is an early childhood mental health consultation program at child development centers. And child development centers are part of a movement that says they are schools too and should be recognized as schools because they are learning institutions for children birth to 3 and birth to 5 and all of that. They may not be chartered, they may not be public schools, but they do serve the same populations that feed into all these schools. So it's the same community. And to not include those early childhood centers in the expansion for school-based mental health is a grave error. Not to mention that Healthy Futures is one of the only programs that's actually named in the South Capitol Street Memorial Act, right? And that early childhood is stated in the act to be the area of growth to the child development centers. So we are not on the ball in terms of the expansion for that to happen. And the 4 whatever million that she noted that Healthy Futures has, that is not a cut. In the PAVE meeting that I mentioned, when Deputy Mayor Kine said that Healthy Futures was returning to its pre-pandemic funding levels. So it's almost as if the pandemic never happened, that so many children under 6 years old are not suffering for not being identified, that DC doesn't already have these pre-existing issues with identifying children very young for disabilities, that many providers in the school-based mental health system are not able to provide the necessary care for mental health supports for young children. And that if you're a licensed clinician, does not mean, and you have never had any interaction with youth or children and young children, that you are not, no matter, the kind of deification that happens with licensed people through the Medicaid system as the only people that can bill it, that does not automatically give you the knowledge, the expertise, the understanding, the compassion, and the interest to work with young children and support their mental health, very young children from birth and on, pregnant people and on. And then to add on top of that, from a early childhood special education lens, right? Healthy Futures needs additional endorsements, funding, more funding, higher than pre-pandemic. It's insult upon injury. Yes, you lost the federal portion of the grant. Yes, that worst case scenario, people can retain a private provider and some other, and may be able to pay that person through Medicaid or through private insurance. But for our most vulnerable families, they're not going to get early intervention. And we know that disparities show that children who do not get early intervention and are identified later in life tend to be more prone to the worst outcomes, social outcomes, in terms of political determination of health. So as an early interventionist, the one who's passionate, I do not support this message that is being circulated to advocates and throughout the city and to our lawmakers that Healthy Futures is okay because it received no cuts. It received a form of cut, right? Which is the cut of, of non-investment, not adequate investment for the program to grow. So I do see Shanta here. And private insurance, how does that happen? How does that happen in schools? They should not be billing in schools. Shanta, if you come on camera, I'm going to bring you up on, and we can have a quick chat. And please, we've gone over for the past few weeks, and so I apologize. But I'm going to add Shanta to the stream. Shanta, are you there?
I'm here. Can you hear me?
I can.
Great. So my browser is actually blocking the cam, but I can speak and I can hear you. So I hope that's sufficient.
Yeah, no, of course. Appreciate that. I know you're a caregiver, you're doing caregiving in real time, and appreciate your time here. So I just want to read a little bit about you from your profile here, and I got your picture, but I wasn't able to, in interest of time, I wasn't able to get it
No
uh,
problem.
on the screen. But as part of Shanta's bio, it says that Shanta is a woman, a caregiver, an advocate, encompassed into one being. She aims to create a positive impact in the lives of others, regardless of the labels that have been placed on them. She's able to connect the dots where others cannot. And that is legit. I mean, Shanta is the real deal, Holyfield, in terms of, I mean, if there is a peer supporter that's out here doing the best work for our communities, Shanta Jones is on that list, and is and ask for nothing in return, which I wish you would, do, and take care of your household. But you have so many things to offer. I want to give you the floor to just tell us a bit about you. I know you're homeschooling. Are you a Washingtonian? Are you caregiving? Do you identify as disabled? Are you raising a child with disability? Let us know a little bit about you, Shanta.
Okay, great. Thanks, Chioma, for that introduction. So yes, I'm born and raised in Washington, D.C. And what we're doing right now in my household, my son is 20 years old. His diagnosis is autism. So what we've done is we've actually moved away or transitioned from DCPS, and we did it at a very early age. He was 13, and we created a day for him of medical services. And I was forced to do that because the school system, it wasn't the appropriate setting for him. And even the private schools or the private placements, none of those were appropriate either. He progressed so much more receiving outside services than he did combined within DCPS. And that includes any aftercare services he received. So we're still incorporating, let's say, ADLs. He's receiving ABA. He's also,
Activities of daily living,
yes, I'm
ADLs.
sorry, activities of daily living. Because honestly, that's all he was getting in school anyway. His curriculum was based off of activities of daily living, but they weren't actually sufficient or efficient. They were very, very, it was the bare minimum. When I removed my son from school, he still wasn't tying his shoes. He couldn't hold a butter knife. He wasn't making sandwiches. He didn't progress any skills as far as swimming, cycling, any of that. So most of the things that I've just named, he's actually accomplished. And again, we have created an entire day of outside services. He's also enrolled in DDS. So he's receiving respite as well as companion care. And the highlight of companion care is a parent, a caregiver, a family member, a friend can actually offer that service and get paid to do that for the individual with special needs or with a disability. I can't speak enough about ABA. ABA was a life changer for us. And I really did have to fight tooth and nail in the school system, and they didn't budge. They refused to budge. The money is there. The most I've seen is they will contract at times with outside ABA providers to bring them within the school system for particular children. But a lot of times it's because that individual's behavior has literally become a safety issue for everyone. So there are no preventive measures. Most of the measures that come with ABA, if you see it within the school system, is reactive. So something has happened. Whereas on the outside of school services, we're actually able to incorporate that into the activities of daily living. So we're using replacement behaviors, which again can also be preventive, because once you know that that individual actually has these behaviors and what triggers the behaviors, and if you see that there's a need for that behavior, then you offer a replacement behavior.
So we're talking about Medicaid as as a protective factor and, potential pitfalls. So now just walk me through like your day as a homeschooler. Do you consider yourself as having a medical home?
Sure,
Sure.
definitely.
So on an average day, like is your son receiving services in the home or
Yeah, so we're receiving services in the home because I am the companion caregiver. When we step out of the home to do the ABA, I'm still there because I'm still listed as the companion caregiver. So that also provides me the opportunity for parent training. So I'm very involved. I can see what's going on. I can see the progress within the community as well. Um, and
so
things,
can I ask you this, as a companion caregiver, does that mean that you're paid to be your child's caregiver?
I'm paid to be a companion at that point. So just like someone needs support of a person to accompany them.
Okay. Okay.
Okay.
That doesn't seem like it's easy to set up. Was that easy to set up where that you would actually, because I think in senior care or adult care, it's easier, but children under 18, it's harder. Is your child over 18 or under
He's
18?
over 18, so he's 20, and
Oh,
that service is
yeah.
through DDS.
Right.
So, yes, under DDS, it's easy because it's already a service, it's there. Whereas with health services, it would be considered a PCA or personal care aid.
Yes.
And a parent or caregiver would then need to be hired by an actual nursing company to actually render the services that I am rendering.
Okay, so so for those who may not know, right, there are personal care agencies that specifically serve children under 18 in the home, in medical homes. Those are homes that receive Medicaid services through waivers for children in the home. But, the staff that comes in is usually external into the home. Sometimes they can be very traumatic in terms of their knowledge of your household, cultural fit, understanding of your child's disability, all of that. So it's very rare and hard for a parent with a child under 18 to receive services, to say, okay, listen, I'm going to quit my job and I'm going to become my child's full-time caregiver. There's more red tape for that because, as Shanta just mentioned, you would have to then go apply for a job. You'd be treated like an employee of an agency that serves your child. So, and that means you'd have to go pay for your certification, which isn't free, right? And then you'd have to, complete whatever testing comes from that. And then you'd have to then become eligible to be employed and paid. But on the adult services, Shanta, how does that work?
So
Do
on the
you
adult, on the adult services, for clarity, you're still treated as an employee, but because the service has already been implemented, there's not as much red tape. For instance, there are providers. There's a list of providers. You choose a provider, you turn in the paperwork, and the paperwork is normally your ID, so security card, your high school diploma, and of lately your vaccination status. And then you get hired by that company and you work with the individual that you're raising.
Okay. All
Now
right.
I just also want to mention that's also, it's given upon approval of a particular service, which is companion care. So there's still a small process, but it's easier.
It's
Sorry,
easier,
my
but
son is running from the dog. Yeah, so it's a bit easier. Yes.
do you have to get an HHA or a CNA license? Did you have to get a
No,
license? No.
no, you just need your high school diploma.
Okay. Okay. I mean, that is a huge barrier lift, versus in the children's space where,
Yeah.
yeah. So I mean, okay, so you're able to do that. Um, you're able to be a companion. It brings resources in the home for you as well as your child, and then access to other treatment and care. Like, how do you find your Medicaid? We talked about transportation. There was a question. Let me bring that question back up. Maybe we could talk about this. It says, how can high functioning kids, and that language. High functioning kids or low needs kids with IEPs maximize Medicaid billable services in schools, and can Medicaid transportation services be used for out of school time? And the reason why I really want you to talk about this, because you were on that call when HSCSN was in the meeting with the Department of Healthcare Finance, for the Family Support Council for the Department of Disability Services, which we're both on. And there was a lot of heat, a lot of smoke for transportation. I just want you to enlighten us on what it's like to rely on Medicaid transportation. Is that a better option than OCDOT? You know both sides of this question. What are your thoughts?
I think it's bittersweet. I think that there's a system in place, and for advocates and for caregivers, our number one priority is safety, but it should also be to ensure that services work the way they're supposed to. Okay. If you have a child where they have low needs, it's possible that there are many things that can be done. If you're talking about transporting the individual from school directly to a medically prescribed service or therapy, yes, that is possible. You can either get DCPS to transport from school to that location, but the other option is you can also get Medicaid transportation to pick up the individual from school and transport them to the medical therapy place. So you have your options. You just need to know those two options are available. In between that, if the individual needs an escort, that escort can be picked up first, transported to the school to pick up the individual, and then transported to the medical therapy center. So yes, all of those things are options. You just need to know what those options are.
Now, in terms of quality.
Now, in terms of quality, it can look very different. Let's say for Medicaid, for HSCSN, an option is also for Lyft. You need to know that Lyft is an option. It's not only an option for emergency, it is a listed member benefit. So I would encourage that all members use this benefit.
Yes. Now, I hope we got that right. That Lyft is an option for use for Medicaid through your managed care organization. And if OCDOT does mess up, I mean, don't you have to go through approval for that to use Lyft?
So for transportation, because the medically prescribed service has already been authorized by Medicaid, they already know that this individual more than likely would need transportation. So you literally would make a phone call or email, whichever your mode of communication is, and you would explain to the care manager you require transportation. And if this transportation is on a daily or weekly basis, it's so much easier to get it as a standing order. And a standing order just means that this authorization for transportation is in place longer, so you don't have to call every day or every week. And the care manager will set that up. And again, it can be utilized through Lyft. It needs to be detailed who's getting picked up first, who's getting picked up second, the drop off, and then the return trip. And normally transportation is then authorized.
Yeah, no, that's all very, very helpful. So Solanda, can you clarify what you mean by private insurance? How does that happen in terms of schools? How money moves? If the school asks, does your child have private insurance? Can you provide that information? The school cannot bill you without your consent, but you can have a provider who, again, does claims-based billing, and they would need your consent to bill you, should they be able to do that, but they would be billing you as a private provider, not as part of the school's allotted budget from healthcare finance. And it also helps the schools know who has insurance, who doesn't have insurance, and that justifies if that school is going to be eligible for the random moments in time funds that come in to the schools directly from healthcare finance. So there's Medicaid dollars that goes directly to the schools that has nothing to do with the services and the Medicaid money that is used for home and community-based services. Yes, Yes, and there's some people who have both, right? Who their child has both insurances, but they would consider your private insurance your primary payer, and then
Correct.
secondary payer would be Medicaid. You want to add anything to that?
No, you're absolutely right. I was reading the comments. Ms. Rob asks, shouldn't DCPS and charter required for ABA, but OT and speech is? Shouldn't that all go together? Okay. I think what she's asking is, shouldn't ABA be a requirement? It should be. I think parents can push this. The only downfall I can see with having ABA in the schools is at some point the schools would want to control the providers.
Yeah.
And once the schools get to a position where they can do that, then that means that they can control the amount of hours and then the quality of the service. So I
Yeah.
always tell parents, if you want quality ABA, go outside of the schools.
Hear that fun tip? You know, that pro tip. If you want quality ABA, I mean, first of all, I mean, so can you talk about why you pulled your child out of schools? What were some of the factors that kind of went into that? And was that hard for you to do?
Sure. So I'll talk about that. My son started the school when he was 3 years old. By the time he was 10, it was little to no progression. And we're talking about a child who was gluten-free, casein-free. He was nonverbal. And when he started at 3, the main issue was, or the behavior issue was that he was a runner. He was labeled a runner. By the time he was 10, we're talking about aggression. There's the sensory issues. It was almost an overload that just laid out the pathway for all the inappropriate behaviors. So year after year, I'm continuously sitting down at the IEP meeting, asking questions in reference to OT, in reference to ABA. And what I noticed was there was a high turnaround for the aides. Literally every year, my son had a different aide. So that showed me there was a lack of consistency just in the staff and administration. And when I started comparing his IEP and the goals year after year, I noticed that it was literally copied and pasted. So it was literally little to no
Another parent
progression.
pointed that out. Yeah, Solanda. So I think Solanda pointed that out. That happened to her too. That happened to me as well. I have a
Yeah,
personal experience with that.
yeah. And it became apparent that my son just wasn't going to be successful. So what I did was I started researching what was out there, floor time, playtime, ABA. I did a lot of research. And when I took it back to the school, the response I received was basically, oh, well, we can offer ABA mythology. But when I asked what that was, no one at the table could tell me. So I knew that if I kept him in this environment, eventually I would have a child that I would be scared of, that I would no longer be able to love and take care of safely.
Ooh.
Yeah, I knew it. And I knew it because I saw the older population in this school.
Yes.
So I saw it with my own eyes. And my goal was to prevent that. So I did. I actually started litigation against DCPS. I sought services on the outside. I started litigation against Medicaid. I won against Medicaid. And slowly but surely, I started implementing the services outside of school. And it was hard. I don't even know how I got through that at that time. For instance, when I pulled him out of school, I pulled him out of school. We were getting ABA twice a week for 2 hours in Virginia. I would literally drop him off for 2 hours. I would go around the corner to Panera and wait, go back and pick him up, and we would head home. The other 3 days, I decided that if the ABA was to be effective, there's no way I could send him to school those 3 days. It would make it seem as if all of this would be for nothing. So I
Yeah.
did. I learned about ABA. There's online training for parents. You can get your certificates. I encourage parents to do this. You will learn a lot. It took almost 3 months for us to increase his schedule because I took whatever was available. By
Yeah.
that third month, we were able to squeeze in 5 days a week.
Wow.
So I did end up quitting my job. I didn't have a choice because I didn't have anyone who was qualified to watch him the other 3 days. So I did, and it was hard. I do not, what I did, I would never suggest to anyone else because I still don't understand how I made it through that. So even with my lived experience, I always tell parents that portion of my life, do not copy that. Like, don't do that to yourself. But we're here and we made it. I wish parents would understand that big booklet that they give you at the IEP meetings where it
Yeah.
outlines your rights and responsibilities.
The
It is
procedural
so,
safeguards.
yes, it
Yeah.
is so important for you to read them, reread them, get with another parent, and comprehend what are on those pages
Yeah.
because it's a game changer. The IDEA, it is a game changer.
Yeah. Shanta, can you share the link for the online course if you can? And if
The
not, if
online
do it
course,
offline.
let me
Yeah.
see. I might have to give it to you.
Yep. And I will share with the
Yeah,
cohort.
because it's in my other phone and they actually offer a disc. When I did it, it was $50 because they offered me a $50 discount for caregivers. So they know how important this is.
Yeah. No,
So
that's
yeah, I
really,
encourage all parents to go through that training, get a certificate. If you ever want to do ABA, do it. If you just want to do it in the home, that's fine too. But trust me, it is worth it. Because that's the only way you'll know what quality looks like if you actually take the training yourself.
yeah. Yeah. So, on the topic of Medicaid, would you say that Medicaid has been helpful? I mean, I know that it was hard for you to make that decision, but you made. I mean, to me, it sounds like the absolute right decision, based on all those factors that we are all facing. And to be honest, I am contemplating what I'm supposed to be doing, for my oldest son, particularly, who is showing more behavioral, he's acting out a lot more as he gets into his teenage years, right? But do you feel that Medicaid, would you been able to do this without Medicaid?
Absolutely not.
Right. So to you it's an asset, right? Or
It's
are there
it's
issues?
definitely no, it's an asset. But
It's an
again, it will only work as good as you work it.
Mm, yes. And there's so
There's a
much
there's a
more.
Medicaid handbook. There's a rule book for Medicaid as well. And you
Mm,
would be surprised what's in there.
say more. Like, how do you access, where do you find a copy of the Medicaid ruling?
That one was online. My last attorney, when I started litigation with HSCSM, my attorney actually gave me the handbook, but it's
Oh,
online. I'll get that to you too. I'm just writing this down so I
yeah.
can give
And
you that info so you can pass it along.
so now we've talked, I know, and I really wanted you to be more able to be active within this cohort. Like,
Yeah,
actually, even before we started doing this, I was like, Shanta, right?
yeah,
Just, but later in the year, I do hope that you join in terms of the Neuro Mama Co-op, because the dream and the vision of that is to be able to bring dynamic caregivers like yourself to work with pregnant people and young families with young children who are just starting their disability journey or just coming into terms, of their disability journey, because you're a wealth of information, through your lived experience. I mean, if there was a poster, and even if you're off camera, a picture of somebody who was the ideal peer support specialist. That is Shanta Jones, right? Like, you know a lot, you give a lot, and your information is sound and replicable. So, I mean, I look forward to working more together. I hope that we make sure, I know that you're studying now and that there are more opportunities to engage. I do want to maybe present one last thing and then let you have your night back, and
Okay.
and also our participants, people who are tuning in. So there is one more thing. So I, shout out to Eric Call, who does Medicaid policy work for the DC Special Ed Co-op. And he introduced this to me. He said that there is what is called the Safer Communities Act, which is a federal act. And I'm going to read it verbatim. It says, as the president outlined in a State of Union address, we must do more to tackle our nation's growing mental health crisis, which is particularly acute among our youth, says domestic policy advisor to the president, Susan Rice. The new awards will help connect more students in need to school-based mental health services now and ensure a pipeline of trained professionals to support students in the future. Integrating mental health services in our schools is a key component of the president's mental health strategy and will help fulfill a key component of the president's unity agenda. Even before the disruption, isolation, and trauma of the pandemic, youth rates of anxiety, depression, and other mental health challenges were on the rise, and too many students suffered in silence, said U.S. Secretary of Education Miguel Cardona. Mental health and wellness have profound implications for students, their academic success, and their overall outcomes. And we know that youth facing mental health challenges are more likely to receive services in a school-based setting. The bipartisan Safer Communities Act represents an unprecedented opportunity to raise the bar for our support of our students, to improve learning conditions in our schools, to expand access to school-based mental health care, and to supercharge efforts across the country to change and hire pipeline of professionals committed to the well-being of our students. So this is from U.S. Department of Ed. And there's a very short video that I want to play, and then I want to get your feedback on this. So the video is from a Republican lawmaker. Okay. So let's go back a little bit. Start here.
I would say the topic today, tragic in so many ways, but I think moving forward in others. Last month, 19 kids were killed in their own schoolrooms. 2 teachers were killed at Uvalde, Texas. It was a horrific act, agonizing thing for family, an agonizing thing for community. And I think along with the Buffalo, New York event, an agonizing thing for our country. One thing that almost all these mass shootings have in common is a perpetrator who had a mental health issue that wasn't dealt with properly. And let me say, before Senator Stabenow and I talk any more about mental health, and I believe I'll repeat this again to be sure we know what we're talking about here. People with mental health conditions are not dangerous. Mental health is a health issue, and we ought to treat it as a health issue. But in rare and tragic occasions, people with a mental health issue undealt with can become dangerous. And that's what we've seen in this and other similar circumstances. And so one of the responses is always, well, we need to have a better mental health delivery system. And that's true. But we should realize that according to National Institute of Health, for at least a decade now, they've estimated that at least 1 in 5 Americans has a diagnosable and almost always treatable mental health or behavioral health issue. And frankly, the pandemic made that even greater. A June 2020 survey by the Centers for Disease Control and Prevention found that 41% of adults in the United States said they'd had at least one symptom of a mental health condition in a recent time. And 11% said they'd seriously considered suicide in the previous month. Now, those are extraordinary numbers, but even if they were, half of those numbers were correct, you see the size of the problem we have and the importance of dealing with that problem. Of course, we had even more alarming numbers with children and young adults during that, lockdowns, months of virtual learning, time away from their friends. I'd argue too much time on screens. The effect of the pandemic on close family members had a staggering toll on the country. Children's hospitals saw mental health emergencies among 5 to 17-year-olds increase by 14% in the first half of 2021 compared to 2019, and a 45% increase in self-injury and suicide for children in that age group. Pediatric hospital needs, pediatric mental health care needs are greater than they've ever been. We need to be sure that everyone who has a mental health crisis or has an ongoing mental health problem has the help that they need when they need it. The bipartisan legislation we're debating today expands access to high quality mental health and behavioral health through what Senator Stabenow and I will point out we believe to be a truly proven model of community-based care. The Excellence in Mental Health program, a program that we brought to the floor in 2013 and then got signed into law in 2014. At the time, Senator Stabenow mentioned that bill marked the most significant expansion of community mental health and addiction services in decades. When we pass this bill, it will be even more dramatic in its long-term impact. And we've worked on these issues together with pilot states. We've worked on these issues together that brought.
Okay, I'm gonna stop there and maybe just explain a little bit more about what this act is supposed to be doing here. As far as I understand, and I'm still doing my research on it, it's funding that's earmarked for behavioral health support that's supposed to go out to states, but states have to apply for it. And so this law was passed June last year in 2022 by Congress, and the opportunities are there for Department of Healthcare Finance, OSSI, DCPS, the Deputy of Education, to seek federal funding once, I think there's like they have to do it this year. They have to do it soon. By the end of this year, they have to show interest and make their, provide a case, apply. And again, I just heard about this like the other day. And so that means there is potential for additional resources for school-based mental health. What do you think of this, Shanta? What do you think of this?
Okay, so let me tell you my experience of being offered school-based mental health. About 7 years ago, there was a MDT meeting, multidisciplinary team meeting. And the issue was they were trying to bring my son back into the school. I met with the school-based mental health provider who was a contractor through DBH. So I always, go through the protocol and then I'll review it, or then I'll advocate for what it is that I know my child needs. So we set up in a room and we just had one telephone, and he asked me like what it is that I need. And I said, first of all, my son needs ABA. He had no idea what that was. So I asked him, I said, well, what is it that you can do? If you don't know what ABA is, and I had explained the diagnosis of autism. So what he decided to do was to call around to some DBH providers and ask if they offer ABA. All of them said no, because they don't. So what happens is school-based mental health, it does not directly address behaviors or the consequences of the mental health or the behavioral health issue. So I want parents to understand that. So if you have an individual who has autism, who might be verbal, who's now saying that they hear voices or they're feeling touches while they're in school.
Hmm.
Remind you, do not forget that everyone who works in that school building is a mandated reporter.
That's
So you
right.
have to be careful about how much access these administrators and these teachers and these therapists within the school systems have with to your children. Because
100.
although you'll say, I need assistance, what do I do? And if you don't take the route that they are suggesting, you might get a call from CFSA stating that the school actually called and make this complaint or called for concern. So to me, school-based mental health is there, but I haven't seen it be effective or be impactful. What does
Yeah.
that look like? I still don't know. I don't know what it looks like. I don't know who the staff would be, the agencies it would come from. Where does the funding come from? Can you opt out? So if they make a recommendation, can you opt out as a caregiver, as a parent? Can you opt out?
Yeah. Can you opt out? Good question. Good question. I think we need to follow up on
Yeah,
the opt out. Like we can opt in, but can we opt out?
right,
Good point. I don't know the answer to
right.
that. So, I mean, that's really, really important. And the fact that this conversation, I mean, I've been, working in the space of school-based mental health for almost 7 years now. And now it's reached the level of the federal government is talking about it and is allotting monies to it. Um, in your opinion, do you feel that like the route that you made, as painful as it was a better move to make? Or I don't know if that's really a fair question to ask, considering it's a different era, different time. But do you think there are opportunities for parents to replicate what you did in a certain way and find more power in that than potentially keep relying on the public school systems, which, looking at the budget season this year, it seems like, yeah, no, I can't keep playing with people who are playing with my children. Like, it's not funny.
Absolutely. Absolutely. I think if we go back 2.5, almost 3 years, my case is very similar to most of the parents because although parents say I can't homeschool and I can't, you literally just did it. You
Hmm.
just did it. So if we can really look outside of ourselves instead of saying what we can't and can't do, we can also say, okay, guess what? If I had to, could I do it? Because we have to remember, we can't get any of this time back. Not
No.
1 second. We don't get any do-overs or redos. We don't. And it's already complicated enough to try to be consistent just in our personal lives at home with these individuals that we're raising. And like you said, I don't allow people to play with my child, not his future, not his money, anything. So I
That's right.
think parents right now need to stand up and say, to school boards, to council members, to ANCs, to these districts and say, guess what? No more. We are not accepting this anymore. Literally through the pandemic, you
Yeah.
fed your children. Okay, so you was a personal chef. You had to log them on.
Yeah.
And most of us had to sit there. Most parents had to sit there.
Yeah. I mean, it was the worst. Like,
It
it
was
was the
the
worst.
worst. It was the worst. I think we need to be creative and we need to teach the school systems that
Yeah.
we deserve options. Our children deserve other options. It shouldn't just be, okay, they either go to school or homeschool. What if there's a mixture of both? What if there's an option for a mixture of both?
Mm.
And then there's another option to say, okay, I'm going to opt out of all of this and I want to go straight to Medicaid. I want to go straight to my insurance and build a full day of quality services, OT, PT, speech, ABA, fitness. I mean, it's there.
It's there.
But I want to remind parents that there's a life after school. Okay, for our children, even though our children go longer than their peers, there is life after school. So if you burn yourself out with testifying all the time about transportation, writing these letters to congresswomen and congressmen, and going to the schools and crying. If you do all of that, there won't be anything left on their journey
For the
after
children.
school.
Yeah.
Yes, after,
Yeah.
like, there is life after school, sex education, job readiness. I mean, there's so much more after school.
That
Once they
Medicaid should be
graduate,
paying for,
that
right?
Medicaid
Medicaid, yeah.
Medicaid will pay for, will
Medicaid
pay for.
will pay for.
The school will drop them at 22. I don't care if that's the favorite student or not. At 22, your child will receive that certificate of completion. If they're on a diploma track at 18, 19, they're going to receive that diploma, and that's it. For some parents, transition services work, but for most parents, they will tell you that they didn't know what to do after they received that certificate or that high school diploma.
Yeah.
So while your child is in school now, try to figure out what life looks like for them after school. Because otherwise, you'll be stuck. You'll leave them in this institution or that educational setting longer than necessary.
Hmm. Yeah, so if your child is sitting in preschool right now and 2 years
Hmm.
old, or you're pregnant, like, it's
Hmm.
not too early to start visioning that world. Like, what is
Right,
that world going to look like for your child?
right. Funds, the financial piece is the most important.
Yes,
Once these
100%.
children turn 18, if they qualify for SSI, what does that look like? What can they own? How much can they own? The school is not going to answer those questions for you. You're going to have to link up with other parents. You're going to have to find an attorney. You're going to have to call SSI, and it's work. But
And
there
it's
is
work.
life after school. Do not burn yourself out fighting a school system. Because on the other
Hmm.
end, on the other side of that door, there's Medicaid saying, hey, here we are. What do you need?
Oof. I mean, that is sound advice. And I'm gonna chew on that for a little bit, because it's a lot to, like, switch paces. I do want to share this last thing for those. I've seen this circulate, so many, the who's who of special education, DC, or education DC. So this is an event with the Office of the Student Advocate and Ward 7 Education Council and PAVE. And then there's going to be partners from DDS, from OSSI, from Special Ed Hub, which is the Ombudsman's Office, Children's Law Center, Advocates for Justice, Early Stages, da. And it's Learn Your Rights in the DC Special Education System, Engage. There's a QR code. There's this link, registration link. I'm going to drop it in the chat on YouTube. So just doing my due diligence here to spread the word. But I do well receive the wisdom that Shanta has dropped on us here, right? Like, it's a marathon. It's not a sprint. If we burn ourselves out, if we let the dysfunction of the systems burn us out, we won't have that energy when we really need it, when our kids are the most at risk in their transition into adulthood. So much to digest, so much to understand in terms of Medicaid, and how we can use it as an empowerment tool, and how we can reduce maybe some of the harms that may come along with that. So I thank
Kiana,
you
one more
all.
thing.
Mhm.
One more thing. Sorry about this. In reference to transportation, if parents choose to transport their own children to and from school, there is a reimbursement option.
Oh,
And
well,
there's
yeah. Now you
also,
have to apply for it. Like, it's no longer
yeah,
like,
yeah, I heard
yeah.
that. Yeah. And then there's also a reimbursement option on Medicaid as well.
Oh, so even for Medicaid
Mhm.
transportation, there's a reimbursement.
Sure. So if you was to pick your child up from school and take them to their medically prescribed service, you can get that reimbursed as well. Yeah. So that's an
Yeah, I
additional two
think
options.
so.
Yep.
Through the year, when we start building out Neuromama, like, look, we need to get specific in the hows and the whats, and create systems of support and
Yeah.
managed care. Yeah,
Yes.
no, this is really important. There's so much more to unpack here. We'll call our friends on healthcare finance and whoever else wants to be our friends, to help
Mhm.
us have a better life, as we dig deeper into how to create more sustainable solutions. Well, Shanta, thank you for your time. Thank you,
You're
sister. Like,
welcome.
again, we just know that, I don't see your picture, but I see you. Okay. I
Thank you.
see you. Thank you. Have a
I'm
great
here. I'm
weekend,
always
everybody.
here.
All right. And happy Easter to everybody. Happy Good Friday. All
Same
right.
to you all. Thank you so much.
Be blessed. Bye.
All right. Bye.